In this section, we'll move ahead to treatment planning and implementation of treatment techniques. We're getting more into the nitty-gritty now. So how do we start treatment planning? Think for a minute about what you do when you start treatment planning. What's the first thing you think about? What do you think about next? How specific are you going to get before you start working with that child? Now, this is after you've done the initial assessment. Now, for those of you that are in the schools, I know, having been there myself, you don't really get time to do an initial eval, so you pull them out and you see them for 20 minutes, or maybe at the beginning you get to do somewhat of assessment, but you're having to do assessment over, like, I've seen people say, well, we spent the first month doing assessment. Well, I think that's way too long. You should be able to do assessment of most kids in an hour to 2 hours max. So splitting it up into 15 or 20 minutes isn't really very efficient. So you may have some flexibility, especially at the beginning of the year if you have a new child, but I would suggest that you do your assessment in a short period of time so that you can actually begin with treatment. So how do we start treatment planning? Well, of course, you're going to use your assessment data and your decisions about this relative contribution of phonology versus CAS, etc., this contribution of linguistic and motor impairment. You come to your differential diagnosis, you write your diagnostic statement, and that's going to guide you in all your treatment planning and all those clinical decisions that you have to make, and it's also going to guide you in your goal writing. And for this, I don't mean just writing out your initial recommendations, which will be important, but writing those specific early speech therapy goals. Now remember, your differential diagnosis may change over time, which of course is going to change your treatment plan, and implementation will also change. Your treatment plan is going to change from time to time anyway, even if the diagnosis remains the same, which is the other reason why I always say SOPs that are working in the schools are just my heroes, because it's such a hard place to do speech therapy for this kind of a speech disorder. Our service delivery model in the public schools doesn't lend itself well to high dosage. It doesn't lend itself well to talking with parents because they're not there. It doesn't lend itself well to documenting changes in treatment plans because you write them for 9 months, which, as you all know, makes no sense. So the dictates of our job that are imposed on us sometimes get in the way of what we really need to do in terms of clinical thinking. That doesn't mean we can't do it, keep our own little notes, and then do the paperwork that's required of us in whatever way we have to do that. Remember, as we're thinking about our goals here, that in CAS, the goal, the focus of treatment is to improve that child's ability to do the movement specification or the motor programming, or sometimes we put it in the words to assemble, retrieve, and execute this motor plan for speech. So our goal isn't to teach these accurate movements for all these different co-articulatory contexts. The goal is to improve the efficiency of the motor planning processing, to improve movement specification, and to improve that child's ability to do this on his own, and improve the automaticity of this. So how are we going to do that? Well, we're going to, first of all, and I know I said I would overstate this, we're probably up to 9 already, and I'm going to say it a few more times. The focus is the movement versus the phoneme, or the sound. And that changes everything. It changes the words we use. Remember how I said after I really read the motor learning literature, I realized I had to help that child be aware of and have the intent to improve movement. So now when I talk to them, it's in the context, okay, we're going to work on moving so it's easier to talk. It's certainly going to help dictate the approach we use. We're not going to use a cycles approach if the primary problem is apraxia. It'll certainly help us choose a specific method. Late in this video, I'll be talking about a beautiful systematic review that was done and published, which did a lot of research for us. It reviewed the entire literature in terms of treatment efficacy and carefully showed us which ones have been shown to be effective for kids at different levels of severity. So you're going to choose your method based on to what degree the child has CAS characteristics and at what level of severity. It's going to influence our choice of techniques. What kind of cueing strategies are we going to use? Because most methods bring in a variety of cueing strategies, and if they don't, you still can implement them within that method if you choose to. It'll influence your choice in types of cueing. Certainly, it's going to influence the organization of practice during the session, and it will influence the type and amount of feedback, because the more you decide that this child has a motor level of impairment, the more you're going to want to implement these principles of motor learning. So when the focus of treatment is on the movement, all of these things become more important. General principles of treatment include focusing on movement performance drill meaning we have to get lots of practice, movement patterns, and sequences of movement. I mean, this is really what we're focusing on in terms of these general principles of treatment. Many people recommend intensive, frequent, systematic practice, not just to get the movements accurate, but to work on habituation of the movement patterns so that the kids don't have to work so hard at being conscious about what they're doing. This is a salient part of all the treatments that I've read about to improve motor skill. These approaches also should include hierarchies of stimuli that are carefully chosen, the use of decreased rate to improve proprioceptive processing, and sometimes pairing speech movement sequences with facilitators like prosody and maybe even limb movement. The next few slides are just repetition of this idea of why we're so focused on sounds and why this is kind of a paradigmatic approach to thinking about treatment. Students and clinicians are so accustomed to thinking in terms of sound errors and treating sound production that it's hard almost to switch to think about it any other way. But for children with apraxia, it really helps us, if we can, get past what we're used to doing and thinking more about the focus being these movement transitions. So how does one focus treatment on movement? Well, it depends on what the nature of the movement problem is. If the nature of the impairment is weakness due to flaccidity or spasticity, such as might occur in dysarthria, movement is treated by improving the physiologic support to the degree that we can, and or then providing compensatory strategies for things to improve intelligibility when we've maxed out on what we can physiologically change. But the movement disorder and apraxia of speech is characterized not by weakness, but by difficulty achieving articulatory configurations and then transitioning into and out of these as continuous movement occurs during continuous speech. So practice needs to be focused on making those movement transitions in the context of speech. And as we've said, first with maximum support to get them accurate through visual, tactile, auditory models and cues, and then fading those cues over time. And as we've said many times today, we'll use the principles of motor learning to guide our decisions about how to do that. So we've written our diagnostic statement. We've started thinking about all the clinical decisions we have to make. We have to choose a method. We have to, choose an approach first, a linguistic approach versus a motor approach. Within a motor approach, we have to choose from a number of different methods for treating CAS. We have a systematic review to help us do that, which I'll review a little bit later. We have to make initial recommendations, which we'll discuss in a few minutes. And we also have to write specific speech goals. And that's where I want to go here with this slide on 109, goal writing. Now, all of us get good at emphasizing measurable behavioral objectives. We learn that in our graduate training programs. We go to work for the schools, and that's what the IEPs require. But I want to, and it's important, you got to be able to know what it is you're measuring and how you're going to measure it. But here's the problem with that. Sometimes when you write a behavioral objective, you can leave out the goal entirely. For example, the child will produce 10 new words by June 1st. Do they not know the word? Am I working on increasing vocabulary? Do they have a voice problem and I'm working through the aphonia so they can actually say the word? Am I working on the phonology for those words? Am I working on motor planning so those words are understandable because of accurate movements? I don't know. So I want to argue that the goal should reflect your clinical thinking about what it is you're actually trying to change. And you can do that with a behavioral objective as well, attached right to it. Let me show you what I mean. This is an example of a written goal for just a specific case. I'll give you the case first and then I'll do the goal. So this is a child I saw at Mayo. It's 5 years, 4 months, had a hypoxia at birth, no current feeding problems. He did have frequent otitis media, but didn't have any. When I got him, there was no measurable hearing loss. He was mildly delayed in meeting developmental milestones. Receptive language was tested to be in the low average range. Expressive language in terms of speech was very low because he only had ma and me with a vowel distortion. He could do ma, but me had the distorted vowel and it was inconsistent. But he had quite a few signs and he could put signs together into short sentences. And he would initiate communication with these signs. MLU, in terms of spoken language, however, was only 1. He had only 3 phonemes, m, n, and p, with only a neutral vowel. So very little vowel differentiation, none really. Very few phonemes. Really, you'd have to call him nonverbal, I would think, rather than low verbal. Assessment showed normal structural functional exam, good respiratory support, normal phonation. He did have significant nonverbal oral apraxia, and his motor speech exam did show numerous characteristics of childhood apraxia of speech. He needed many tries and much cueing in dynamic assessment, but did benefit from that cueing. In the assessment task, he wasn't able to get accurate on very many things at all, but he got quite a bit closer, but it took the maximum cueing allowed on the DIMS. So this was my diagnostic statement, which you've already heard, I think. A 5-year-old male who's exhibiting low average receptive language skills, severe impairment in expressive language, for speech anyway, severe impairment in speech acquisition due primarily to CAS. There's no frank evidence for dysarthria, pragmatically, socially appropriate, focuses attention, attempts all tasks. So here's my initial speech goal. Later we'll talk about recommendations, which actually come before the speech goal. But I want to spend some time specifically on speech therapy goals right now. So what I had written for this child, and there's no one way to do this. This is just an example. Improve his ability to make accurate movement gestures for production of the vowels I, O, and ah in a number of co-articulatory contexts, beginning with M, N, B, H, at 100% accuracy in direct imitation and at 80% accuracy in spontaneous production within 4 weeks, using the initial stimuli, hi, bye, no, mom, knee, home, night-night. So in that case, I've talked about what is it I'm trying to do. I'm trying to get him to be more accurate in his movement gestures for those vowels in those contexts using this stimuli as the vehicle to practice the processing he's not very efficient at. It's not much longer than a behavioral objective you might write in an IEP, and yet it includes really what it is you're trying to change. During the advanced on-site course, we'll have a lot of additional practice in writing specific goals for children that are at very different levels of severity, different ages, etc. And we'll talk more specifically and actually practice writing IEPs that help bring your clinical thinking into it a little more, even if you can't put it all on the IEP paper. All right, going now to speech sound disorders treatment. A few statements with respect to the fact there's a whole range of treatment strategies for children who exhibit speech sound disorders. A number of these intervention strategies are designed specifically for children with motor speech impairment, including childhood apraxia of speech. So if we go back to this diagram of severe speech sound disorders, our differential diagnosis, and on the right we have motor speech impairment, what we're going to talk about specifically now is just those methods that have been discussed and shown to be effective in some cases for childhood apraxia. So what's involved in treatment? See, if we were in the on-site course now, you'd be talking instead of me. But since we're on the video portion, I'm going to do all the talking. I hope you're not bored already. All right. First of all, in my view, the most important thing you have to do early on in treatment is explain this disorder to parents for lots of reasons. One is they get freaked out when they hear the term apraxia of speech. We have to calm them down and let them know it's just a label for a speech disorder. We know how to treat it. Then we have to plan the therapy. What does that mean? Well, that's being the clinician. That's all those clinical decisions you have to make, no matter what method you're using. You have to make all these decisions about how you're going to implement that method. What are the stimuli? How often are you going to see people? What frequency and for what length of session? What are your stimuli? How many stimuli? How am I going to organize practice? All these things are very, very important. They'll change over time. But you have to make these initial clinical decisions. Then, while we're implementing therapy online in the session, we're still making decisions. Should I add more cues? Should I fade the cue? Should I start providing less feedback? We have to be thinking about these things all the time as we work through whatever method you're using. So let's begin with educating parents, and I do like to spend a few minutes on this because parents find me, and they either have read something that I've written or somebody told them that I know something about apraxia of speech, and I'll get these phone calls. And sometimes they're very difficult because the parents will call, they'll be very, very upset. One example that I give a lot when I'm speaking on this topic is a couple from New York who called, and they were each on a line. You know, they were both talking to me on different lines or different extensions, and they had just been to a speech pathologist who had said that their child had apraxia of speech and that they would need a lot of therapy. Well, the term, I think, is what threw them, and they were beside themselves, and they were talking to me. These were educated people, but they had never heard of this, and they were crying. They were asking me if their child would ever be able to talk. They were asking me if this was like a brain tumor. Would he need to see a neurologist right away? And what do you think I was left wondering? Well, I was left wondering what did the speech pathologist say after she used that label? Parents should never leave our side until they have a clear understanding of what apraxia of speech is. And so part of my goal in this video, and certainly in the on-site workshop, is to help you feel confident in explaining this disorder to parents. And I'd like you to be thinking about how are you going to improve your own confidence. If you don't want to or can't come to an advanced workshop where you get more practice, how are you going to practice this at home or with your colleagues so that you feel confident in doing that? On this slide, we're on slide 118 about educating parents. I give another example here of parents that I saw in person. I had evaluated a young boy. He had a very severe speech sound disorder. He had been correctly given the diagnosis of childhood apraxia of speech. That was his primary communicative disorder in his home community. But the parents then were still very anxious about what that meant. And that's why they had come to Mayo. They went online, they found out that Mayo Clinic had people that knew something about this, and they flew to Mayo. And they were still very anxious. They believed it was a medical problem, a medical diagnosis, And they even asked if he would need surgery. So, I didn't pick the most extreme example that ever happened to me either. This was not uncommon for me to get questions like this. They were very distraught. It was even hard for them at first to listen to my explanation after I did confirm the diagnosis. So I just listened for quite a while to all their concerns and questions. And then I was able to start a discussion about the nature of the problem and, most importantly, what we were going to be able to do about it. So here's what we discussed. I began by helping them understand that childhood apraxia of speech is just a label for a subset of children that have a speech sound disorder. Now, we believe that this is neurologic in nature, that there are inefficiencies in neural processing for motor planning and programming, and at some point I'll go over that with parents. But at this point I have to say, but so is dyslexia, right? So are mild learning disabilities. Those are all just inefficiencies. The brain does everything, right? Some of your kids are going to be on traveling sports teams, so they have really good coordination and athletic talent. Some of the kids aren't going to be interested in all of that, and they'll get good at video games because they don't have good coordination. It's not like they don't have it, but there are different levels of coordination in terms of this continuum. We all have different strengths and weaknesses. So even though it's neurologic in origin, and for some children we can identify a real acquired problem like a neonatal stroke or a tumor that causes CAS, among probably other problems too. But for most of the kids we see with CAS, there's no identifiable medical problem that we can say caused it. But whether we can or not, apraxia, childhood apraxia of speech, is just the label for the speech disorder. It may or may not have an identifiable medical etiology. Right there, sometimes parents can really just go, oh, okay. Now, if I'm seeing a child who obviously has other neurologic impairment and they've never been to a neurologist, then I might say, although CAS is just a speech disorder, it can be a symptom of a neurologic problem. But usually we only worry about sending someone to a pediatric neurologist if there are other problems we see also. And in your case, I'm noticing I might say an ataxic gait, or I might say I'm noticing some weakness on his right side, or whatever that might be. It would probably be a good idea for you to see a pediatric neurologist just to rule out any problems. But if they only had CAS, and there were no other neurologic indications at all, I may not be worried about sending them for a medical workup. I explained the difference between a medical and a speech diagnosis. I talked about the nature of childhood apraxia, what it is, and emphasized that there are specific techniques that we know work from our own clinical experience and also from research that's been done. Most importantly, I explained that most children with childhood apraxia of speech will be verbal communicators. And I'm lucky in that sense. That's some advantages to being older, because I've been doing this with a lot of children with severe speech sound disorders for over 40 years, and I've met only a very few that were never verbal communicators. And those were usually kids that I didn't get to see till they were teenagers. They had established augmentative communication systems, etc. But most kids are going to be verbal communicators unless they have significant intellectual disability or severe autism and don't really have intent to communicate. At that point, then I can't make any prediction about speech. But if the primary and typically, the major, if speech sound disorder is the primary problem and childhood apraxia is responsible for it, most of those kids are going to go on to be verbal communicators, and many of them very quickly if they get the appropriate dosage. I then went over my initial goals with them, explaining the rationale for them. I explained my choice of approach, method, initial stimuli, and why I made those decisions. I talked with them about what they are going to be asked to do to help, telling them that it'd be changing as we go along and that I'd be guiding them every step of the way. Now, I do want to say this is easy for those of us that are in private practice or in a clinic or medical setting where the parents bring the kids to us. For those of you in the public schools, it's really hard to do this, but I want you to think about something. If you're in early childhood programs, I think in that case, a lot of times the parents are bringing the children, and I think you would have a better opportunity to talk to the parents. If you're in early childhood and you're going to the family's home, that's terrific because you've got the family there every time. But what if you're in the public schools and you rarely see that parent? Well, think about your caseload. The incidence of childhood apraxia by many estimates is about 5% of speech disordered children. So if you had 100 kids on your caseload, which most people don't anymore, if you did, you'd only have about 5 kids that had significant praxis problems. You'd have others that have a little bit. Well, for those 5 kids, and there'd probably only be 2 or 3 given our caseloads, for those 2 or 3 kids, it seems to me it'd be possible to say it'd be really helpful for your child if you could come in and speak with me when you get off work one night. And I want your son here with us. I want to show you some things. I want to talk to you about really what the nature of this problem is, what we're going to do about it, and how you can be involved in this process at home. And they don't have to be there every time. But when I worked in the schools, and if I had a child with a CAS or severe speech sound disorder that was more mixed, I would have the parents come after work about once a month at the minimum and watch them doing what I wanted them to do at home. And most parents were very happy to do that. In fact, they were thrilled that they had an opportunity to be involved. Now, I know that many of you work in a public school setting where that isn't the case. My stepdaughter is a teacher in North Carolina. And she happens to work in a school district where the parents aren't as involved. Either they just don't have the interest or they're working 2 jobs or whatever, but it's very hard for the teachers in that school to get a lot of help with homework, to get a lot of parental involvement. And I always think about her when I talk about this because she would be the SLP in the audience or at home who might be going, I'm not going to get this kind of parent help. Even if I invite them, they're going to have an excuse why they can't come or they won't feel comfortable coming. Well, I know that's the real world. Think about it this way, guys. To the degree that you can involve parents, the more efficient everything will be. Sometimes we can't do what's best, and that's okay. We can't beat ourselves up for that. But I do encourage you to think outside the box, invite those parents in, and if they'll be involved, that really is helpful. Now, for those of you coming to the Advanced On-Site workshop, we're actually going to practice what we would say to parents. And we'll role play a little bit. And I'll be the parent. And you'll explain it to me and I'll say, well, what does this mean? And what does that mean? And we'll go back and forth. I think you'll find that it will really build your confidence in being able to do this on your own, even if you only see 2 or 3 of these kids a year. Okay, so how do we use clinical thinking as we start treatment planning? I want you to think for just a minute, what decisions do you typically make as you work on your initial treatment plan? Think about what you usually do. Do you finish an assessment or it's Sunday night and you know, oh, I'm starting treatment with a child tomorrow. What am I going to do? And so, or do you think about it driving to work the next day or in the shower that morning? Where are you when you think about this? Do you ever schedule time to sit down and actually write out a treatment plan? For those of us in a clinic or hospital setting, that would typically be done after the evaluation because we have to write all that in our reports that we either dictate or type. But let's just talk about what we have to think about. All those clinical decisions that we said make us a clinician. We have to decide on an approach, motor or linguistic. We have to decide on a specific method with its specified techniques and cueing methods. We have to decide frequency of treatment. How long will the sessions be? We have to make decisions about initial stimuli, about organization of practice, about feedback. And we said that everything we decide is facilitated by these principles of motor learning. You've seen the points that I'm repeating a couple of times because those are the ones that I want you to really remember before you come to this advanced workshop. So, decide an approach. What do we mean by that? Well, it means that we really have to be clear in our own mind about this relative contribution of phonology versus CAS, and because you're going to find both, and where do we want to put most of our effort to get early progress. Now, if the child's deficit for specifying movement or praxis is severe, or the major contributing factor to his communicative disorder, then approach focused on motor skill and motor learning should be emphasized. Doesn't mean we can't bring in some other kinds of approaches, but that's the one that should likely be emphasized. Because linguistic deficits are typically also involved, methods for improving language skills should also be introduced as appropriate. You have to decide where you're going to get the most communicative impact for the therapy you're providing. Then you decide on a method. Now, we're here to talk about apraxia of speech, so I'm going to be reviewing treatment methods specifically designed and tested in some but not all cases for CAS. Not all of these are appropriate for all children with CAS. You're going to make a choice based on severity of the child, the age of the child, the associated deficits of the child. Your choice of method or treatment will probably change over time, and likely you'll be using a combination of treatments over time. So, first we have to decide, once we have our approach and then our method, how often are we going to see these kids? Well, this is where the real world raises its ugly head at times, because what's best for the child isn't always possible. Certainly in the public schools, therapy on a daily basis isn't often the service delivery model. Sometimes, however, I think we can think outside the box and make it happen for those few kids with this level of severity with CAS. And I think the argument for that is our treatment research shows that if you see a child twice a day for half an hour for 6 to 8 weeks, they improve so much that you can then go to a 3-day-a-week treatment schedule and see the same kind of progress. So sometimes trying to organize your practice, even in a public school setting where you're seeing the child very frequently for, let's say, a couple of months, is going to allow you to have that child reach some level of proficiency much earlier. We see the same thing, though, with like recalcitrant R's. We used to have some of the physicians at Mayo who would have a child who's a smart kid but can't do those R's, and he's been in therapy 4 years, and they're getting frustrated about it, and they come to me and say, Edy, why can't he get this? And I said, well, it's probably a dosage thing. He's being seen in the schools, group of 2 or 3. They use the pictures, you say it, you say it, you say it. They're not getting that many practice trials per session, and they're only being seen once or twice a week. So they come in, we bring the parent in for the first couple of sessions. We see them every day for a week. We see them we start a home program with the parent trained to listen, or if the child's old enough, we have them use an iPad, they listen to themselves. So there's home practice, but we really guard against negative practice in a number of different ways. And the iPad's such a nice tool for that kind of thing because we can provide models that they can listen to. Then the next week they come 3 times, the next week 2 times, and then once a week for 2 to 3, whatever it takes, weeks. We have them done usually within a month or 2 where they have the R, sometimes a much shorter period of time. It's all about dosage. Number of trials per session, very frequent sessions. I think if we implemented something like that in the schools, these kids wouldn't have to be in therapy for over a year. They could be through in a couple months, then you bring in the next few kids with ours. So it's the concept that's important. Dosage matters. So to the degree that you can see these kids for shorter and more frequent sessions, the better. sometimes therapists have told me, well, what they do is they see the kids on a schedule that works with their school system, but then they'll grab them for 5 minutes before they go out to recess, or 5 minutes during the lunch period, just in the hall, just work with them a little bit. So, I mean, thinking outside the box can be helpful. Choosing stimuli. As I said, I think this is really important, especially with the more severe kids. And this video and the advanced training, well, this video in particular focuses more on the more severe children, because I think we do a better job of making these decisions with the kids that are a little older or have a little less severity of the CAS. It's these real severe kids that don't have much success early in therapy, especially if we're using more traditional approaches, where we sometimes feel stymied. And so that's why this video is focusing a lot there. In the advanced on-site course, we really go more across age levels. Initial stimuli is important in every case. Choosing how many, what are the length and the syllable shapes and the phonetic content going to be? Are we going to use real words versus nonsense words? In DTTC, we use real words. REST uses nonsense words. In both cases, there are good rationales for doing what we're doing depending on our goal with that method. How are we going to elicit them? Well, in DTTC, I'm suggesting we don't use pictures, because I want the children focused on my face, even though I'm going to fade that after a while. And we may move to pictures when they get much more accurate. At first, I'm not going to use them. There are a number of decisions that you have to make with initial stimuli. We're just going to go over it very briefly in this video, with much more practice in the advanced on-site workshop. So these decisions that, when we're devising the initial stimuli, are directly related to targeting, of course, the movement gestures. And I usually choose initial stimuli based on what vowel distortions are they exhibiting a lot. And I'll choose those vowels in particular syllable shapes based on my motor speech exam results, and I'll vary the co-articulatory context. So that's how I choose my initial stimuli. If the CAS is quite severe, I'm kind of careful to restrict within the stimulus set only 2 new vowels, and then incorporate different co-articulatory contexts for those 2 new ones, and then maybe bring in some novel words that they don't use yet with vowels they already have. I often begin with the child's current phonemic inventory with respect to the consonants as I choose the syllable shapes. Using the vowel targets, I'll then incorporate whatever syllable shape I think is important at this point, CV, VC, reduplicated syllable, or maybe if they're doing better, we can get into some other bisyllables. I'll often bring in 2 monosyllable simple phrases, like me too, if I think my motor speech exam says they can handle it. Very functional, so I think that's a good thing. And you can start working on prosody early, so that's a good thing to do too. Sometimes if I want to introduce a CVC and the child's quite severe, I'll use a CVC that has the first and last phoneme the same. So mom, pop, peep, that kind of thing. Remember to use severity as your guide for choosing the number of stimuli. The more severe the child, the fewer number, but never go less than 5. As I said, when you're choosing your stimuli, over time the child will begin to reach criteria for stimuli more quickly. And at some point you'll feel confident, and as one goes out, instead of just bringing 1 new one in, you'll bring in 2 and raise your set size from 5 to 6 or maybe 7 to 8. Examples are on the next slide, 132, and these are going to vary considerably from child to child, but I've given you just some examples of those that I've used for very severe to moderately severe, etc., and you can just look at those. The idea is to make them functional and really meaningful and useful for the child. So we have renamed pets so that they can actually say the pet's name. We have given kids nicknames so that when people say, "Hi, what's your name?" they can say a name, and the whole family adopts the name. I had one child who, I don't even think he was a teenager yet, talked his parents into going to court and legally changing his name, and they did. and he was happy, they were happy, everybody was happy. So, you know, you got you got to let the kids sometimes help us with these kinds of decisions. All right. Practice, as I said, in choosing initial stimuli with all the rationale why for children with varying degrees of severity and varying ages will be done in the advanced on-site workshop. So the next thing we think about is how is practice organized. We're not going to, this is just review, so I'm just going to put this up on your slides. Blocked, we rarely do only blocked, but we often might go to a modified block even for the severe children. This works really well for younger and more severe children. But within these stimulus sets, we are moving more and more toward random production with each one. So if you've got if their child's real severe and you've only got 5 words, as one word gets accurate and normal rate and you vary the prosody, you're going to start randomly just asking questions throughout the session so they get random practice. And once they meet a certain criteria in your probe testing, and also you've had the opportunity to get a lot of random uncued productions and they're doing well, then you say, okay, we can take that out of training and bring in a new one. All right. Type and frequency of feedback. At this point in a workshop, I would ask you to tell me this because we've gone over this a couple times. Specific, tighten it up, not so big, very early and when severe. You're going to fade that feedback as early as possible, and with respect to both frequency and specificity.